So welcome everybody to our third installation of our machine learning in diagnostic imaging series of seminars. Today's topic is monitoring performance of AI algorithms from Federica Zanca from Group 3R. Let me quickly introduce her, and in the meantime, she can start sharing the screen with her presentation. So Federica is a medical physicist with many years of experience. She has worked in both the academy. She was a professor in the Netherlands, and also she worked in the industry. She is now employed in her own group, in her own. Sorry, I have a technical problem on my computer. Yeah, I hope. Okay, no, the meeting was not interrupted. Sorry, it's just I'm a host. Back to the introduction of Federica. So she has many years of working as a medical physicist in different domains: mammography, CT, interventional radiology, image quality, and then drifting a bit into artificial intelligence. So now she's a consultant for the industry and hospitals. She has her own company, and she's head of R&D at Group 3R, where she leads a team of 4 people, if I remember correctly, and she's leading a few projects on the topic of AI. So today's topic is how to do some quality assurance on AI, how to validate the results, and I stop annoying you and I let Federica take over.
Hello, everyone. Thank you very much, Davide, for the introduction. It's a pleasure for me to be here and to share with you the work we are doing around AI, part of the work we are doing around AI at Group 3R. Indeed, I'm going to talk about monitoring performances of AI algorithm in multi-center settings. So before I start with the real, it doesn't move, so let me check. Okay. Before I start with the real content, I would like to give you a bit of background about our group. So Group 3R is a group of diagnostic centers for imaging in Switzerland. We have 18 connected centers, and we started our AI journey in December 2020 when we signed a contract with an AI orchestrator provider, Incepto Medical, which is a French startup, with whom we are doing this exciting journey. And the different steps we went through are the following. So the first thing, as it is an orchestrator, meaning that there is one provider providing you all commercial AI application. We installed, of course, a gateway. I will come back on that, which is a kind of gatekeepers between, our images and the AI application. And then, step by step, we installed different AI application. The first one was Bone View, which is for trauma X-ray. Then we installed Kairos, which is an application for knee MRI lesion detection, and Transpara, which is an application for 2D, 3D mammography lesion detection. Then we installed the VHS, which is for chest CT lesion detection. Then Pixel Neuro, which is for brain MRI, for cognitive disorders, and then QXR, which is for chest X-ray abnormality detection. Now, as you can see, it was quite a, let's say, a path with a certain timing. We just had a couple of months between one and the other application, which means that our radiologists were all trained to use this application and to interpret the AI report generated by this. Of course, this requested some adaptation in the workflow, which we did. And in fact, the type of workflow, the clinical workflow that we still have today is the following. So we have the indication of the exam, so why the patient comes, the reason that he comes. Then we have the patient who signs or not the consent for having his data treated with AI applications. Once the exam is prescribed in the RIS, it is performed when the patient comes, the images are acquired, they are sent to the PACS for image evaluation. And at this stage, the images are then query retrieved by a gateway. The gateway is still in our local network. It has been installed by the startup Incepta Medical who provide us with the orchestrator. And this gateway has the purpose to, as I said, query retrieve the PACS by using selected filters, which, let's say, query the correct images for the right AI application. And indeed, it sends these query images to the cloud where there is the AI orchestration with the different application. The correct images or exams are sent to the right application. So the mammography exams are sent to Transpara, for example. The results are sent back to the gateway, who send it back to the PACS, where the report is shown to the radiologist as a secondary capture, such that he can look at the clinical images. Next to it, he has the AI report, and then augmented with the AI report, he does his radiology report. This is just an example. Of course, in this process, we have all the pseudonymization process done at the gateway level. And this is an example of filters. For example, for the QXR, which is a planar X-ray chest, we have filters at the level of the patient, the study level, at the level of the image level. We don't have series because, of course, it is a planar X-ray. We do have filters at the level of the series, for example, for CT and MRI. For example, the filters are based on the intended use of the product. In this case, it requires the patient to be adult or almost. In that case, it works for 15 years old patients. So that's why that's one of the first filter, meaning that when the gateway does a query and it receives an exam of, for example, a child who has 14 years, it is not sent to the orchestrator for analysis because it is out of intended use of the machine. So we then have other filter related to the study description, of course, words which are related to our protocol name and study description name, so thorax, chest, poumon in French, pulmon in English, and so on. The modality, it has to be in this case a CR or planar radiography. And the view, for example, it has to be posterior anterior, meaning that in the exclude filters, we exclude every other view or protocol name which contain like view, like lateral or profile in French. So this is just to give you an idea that behind these gateway filters, gateway plus filters, there is a complete setup based on the clinical indication of the application, such that we don't send rubbish to the, to the AI application. So once we have done all this work, which took us quite some time, like at least 6 months to, start the process, having the radiologist acquainted with the use of the application and so on, everything was working fine, or at least we think or thought it was working fine. And then we said, okay, how can we be sure that these applications are working like they are supposed to work? Do we have the safety and the performance that we expect to have when we use them in clinical settings? And that's why the purpose of this study, which is actually just started. So I'm showing you preliminary result. This is not a done study, but I want to show you where we are today and why we did it. So the purpose was really to have a monitoring of real world performance of AI application in clinical settings. So not the typical test we do in a clinical study to, using internal or external data to validate your application, but really to feed a software with data from the clinics and see how this application perform, or what is the safety if we have errors, and so on. So I explained you how the clinical workflow works if you install this application, at least at our group, in the clinical setting. Now, to do this quality assurance, quality control, of course, we had to add layers to this workflow. And the first thing we did was to add a contextual call from the PACS, meaning that in the PACS you have just an icon that you can click on it and it opens another software. And the software is a software which is called Polaris. In this case, it is a software for AI report feedback. So what does this software do? So in fact, I take as an example the report generated by one application that we installed, which is Kairos, which is, as I told you, the application for the detecting lesion in the knee MRI. This is the report as a secondary capture as it is shown in the PACS. The generated reports finding for 7 features. So the meniscus, the ligament, the anterior and the medial cruciate ligament, and the cartilage in 3 compartments. So this is the knee, and you can see, for example, the cartilage, the anterior ligament, the medial ligament, and so on. And the software, the AI software, gives as a report to the radiology really this page, and then it says, okay, if it is orange, in fact, I don't know if it is normal or abnormal. If it is green, I'm sure it is normal. If it is red, I'm sure it is abnormal. But as you know, sometimes AI is also wrong. So we didn't want to have wrong report in our PACS, because sometimes what we do, we also do a copy and paste of the report in our radiology report. So what you don't want is to write in the report, for example, that the cartilage here is normal, but attach an AI which says, well, I'm not sure it is normal, because the patient or the generalist who has sent a patient to our centers then will be confused. So that's why we started using this software, which allows you, in fact, to, as I said, from the PACS, to click on an icon of the software, which is open, and it allows you to change this. So the radiologist can say, okay, you know, I don't agree, this is not dubbed, it is true, it is, green, so there is nothing wrong with it. So to give you an example of a case report edition, this was a case where, for example, there was a lesion in the cartilage. This was indicated as normal in the report of the AI software, which is shown as a secondary capture next to the MRI images. And the radiologist, by clicking on the contextual call in the PACS to open the software for editing the report, he was able to change this from green to red because there was a lesion. Then this report is updated and saved. Of course, this requires some extra time. So at the beginning, the radiologists, they were not very happy because it takes a bit of time if you want to get familiar. But in the meantime, this product, which is also developed by Incepto, has been improved a lot, which allows the radiologist to go much faster than before. And it allows us to collect ground truth data for also improving this algorithm. And I will come back later on that. So, as I said, this is the first thing we did to add some layers to our normal clinical workflow to be able to arrive at an infrastructure which would allow us to do quality control on our AI application. So this was the first. The next thing we did, we implemented, as I said in this example, the sending of the reviewed AE report corrected by the radiologist to the gateway. And this review report is sent back both to the RIS and to the PACS, such that at least in our system, we are sure that the report that we have is going to be the correct one. These are extra layers that were, if you want, not needed for the clinic, strictly speaking, not needed for being able to use in clinical setting the AI, but we wanted to implement to be sure that we have the correct AI report. Currently, this is, let's say, introduced at research level in our departments and only for one application, which is exactly the one I showed you, the knee MRI. But I will tell you later what we are doing to evolve on this topic. And as I said, while this was not strictly speaking, it is still included in the clinical workflow. So it runs really in the normal workflow of a radiologist. The next level of infrastructure that we added are kind of level which run more in the background. So they are in another color, they are in light blue, and I will show them one by one. And that means that the radiologist doesn't see anything about it. The radiologist sees, let's say the clinical workflow is the red one. The rest is in the background, and it is needed for us to do what I will show you. So the first thing we did for the quality control, we wanted to collect more data. So before we could use more data, we needed to be sure that we had the consent for the research, because we need to be compliant with the with the law in Switzerland. And therefore, what we do, we send all the cases of exams for which we have a consent of the patient that we can do research, because after all, this is research and not clinical application. And we also collected more DICOM tag than just the one that are used from the gateway to select the right images for the right application. For example, if I come back to mammo, the gateway must just have filters on 2D mammography with a certain, I don't know, KV setting. I don't think it is the case, but let's say it has a filter on the mammography and some of the DICOM tag, maybe the study ID and so on, but it has nothing respect, for example, to indeed, as I said, exposure parameters, breast thickness, all the relevant information that can be useful for our quality control. So through this, we collect from the images, in this case from the mammo images, all the DICOM tags that can be relevant to us for the quality control that we want to do on this application. This information are sent to the gateway, and from the gateway, we send them to a new software, which we are co-developing with Incepto Medical, which is called QC module, where we collect, in fact, this data. So we have a database where we can do analysis. What do we send also to this QC module? We send, for sure, the AI result, which has not been corrected by the radiologist, and also the one who has been corrected by the radiologist. Because, of course, we want to do the comparison and see where the AI is wrong and correct it if possible. Then what we do is the radiology report, which has been reviewed and corrected, is also sent back to the gateway, is sent back to the RIS and to the PACS. And finally, as we work with structures reporting, the corrected AI report is integrated in our radiology structure report, meaning that the radiologist, for a certain part of his report, he will find a pre-filled content of his report. So, for example, if we think back at the knee with the normal cartilage or an abnormal lesion for the meniscus, which the radiologist has validated if it was correct by default or edited if there was something wrong in the AI report, this information will be found pre-filled in the radiology report. And for this, I won't show you anything about that because this is a study we are just starting. We have sent an abstract to RSNA for that, but I don't have the results yet. But the workflow is in place, which is great. It took us months, but now it works. And eventually, coming back to our QC, this radiology report with the review and corrected AI result is sent back to the QC module. So it's sent back here. So here, in this database, we have all the information we need to do some data mining with respect to safety and performance of this tool. And I apologize, the slide is very dense, but I hope that with the explanation was a bit easier to understand. Okay, so once we have collected all this data, what do we do? Well, the idea, as I said, is to, practically speaking, we want to improve diagnostic performance and we want to reduce also reporting time of the radiologist. on top of checking safety and of the tools. So what we want to do is to define specific metrics, so key performance indicator, which of course are application dependent because the intended use is different based on application. Then we collect the data, as I showed you, through this workflow of clinical data. We try to do data rendering. From this data, we gain knowledge. And thanks to this knowledge, we improve interoperability, we improve the AI model, we change the way we work, and so on. And this is a kind of loop that you do over time. In terms of metrics, we decided to stratify them in operational and clinical. And the operational, we have identified KPIs, which are before any AI application. It means at the level of the gateway, before they are sent to the AI application. And in that case, we are looking, for example, at the application volumetry. So how many of our total amount of breast images for planar or 3D are sent to our gateway to be sent to the AI. For example, do we have 50% of the data that at the end are analyzed by AI, or do we have 100%? This might also be relevant for economic and invoicing reason. We check also how many of these images is rejected by the gateway because they don't match the intended use. For example, age below 14 years, for the example I show you of QXR. Then we have operational KPI after AI application. So we look at the percent of error case. So once they are through the gateway and they are sent to the AI application, how many times we get the result? Do we get it 100% of the time? Do we get it 50% of the time? How many cases we miss it? Why? Then we also look at cases where there is no error, but simply the case is not applicable. And I will show you why. And we also look at overall software utilization. So the complete chain. If I start from all, for example, knee MRI that we do at our centers, how many at the end get a result? If I take into account the one which are rejected for intended use, the error, the not applicable, and so on. And this is just, this is not an exhaustive list of KPIs. It's the first one. These were for us the low-hanging fruit, which didn't require extra integration with the RIS or more complicated data collection, which of course we plan to do in the future. But for now, as I said, it's work in progress, and these are the first steps. Then we go to the clinical. For the clinical, of course, we want to have information on the AI finding distribution, also for epidemiological purposes, for example. We want to see, for example, the percent of AI reports which have been corrected by the radiologist. So how many times the AI is wrong? Why is it wrong? Is it always on the same? Maybe over time it could change because there is data drifting. This is very important to see. And then on the information we have at clinical level, we want to stratify, for example, per lesion type, per radiologist experience, per scanner type, per institution, per patient age, weight, gender, depending on the application, because maybe what we want to see is, does a specific AI software performs much better on one scanner instead of another one? And this is simply because it has been trained on images produced with that scanner. Or do we see an evolution over time? Maybe because we change the processing. We might on CT go from interactive to deep learning, and maybe this has an impact on the findings of AI. So this is in fact the reasoning behind that. So this is the type of KPI we have selected for now on, operational, clinical. And once we have decided which key performance indicator we want to follow, of course, we need to generate graphs and to understand. And this was also quite an exercise because sometimes you risk to produce graphs which have no value, and other times some graphs which are very interesting. So also there we had to learn during the way, and we are still learning by doing. Here, from now on, I will present you some results for a period of about 2 months, part of which have been presented to RSNA this year and others which have been added later. So here I go to the results. So as I told you, remember, we divided them in operational and clinical KPI. The first operation was the volumetry. So this is a very simple, in fact, graph where you can see all the applications which are installed at our center. The total amount, in this case, I think I took just 1 month of data which have been treated by AI, almost 25K, which is not bad. We see, for example, that the application which is used the most is bone view, followed by, for example, the Transpara, QXR, and so on. And we can also do, we have 18 centers. As I told you, we can also do stratification per center. I didn't do here because I prefer to, for example, to share you something on volumetry. And you will see very soon why. So here you can see, for example, the 5 days of the week, where you have the utilization of the different application. Again, the majority, you can see that it is bone view. Then we have some Kairos, then we have Transpara. And you can see that we are quite stable in the utilizations. There are no big fluctuation. Of course, in the weekend, we just do bone view because it is fracture, and that's probably why they are there. And so on. So it looks like a quite boring, I say graphs, but we had some very interesting finding. So for example, you can here, so excuse me, if I go back here, you can drill, if you click here, you drill on one application. So if you drill, for example, on Kairos, which is what I did, what we found was that, yes, here we have some, the data of the week. In the weekend, we don't do any Kairos application because it is not, it's knee MRI, and it is not like fracture that you might happen to have in the weekend. And but what it is interesting that at a certain point we had actually no data. So we had 1 day where we had no data which had been processed, and the reasons for that was, I will show you later, one of the typical error you might have is that the gateway which is processing the data entered into in a loop, and it was not able to process data anymore, which means that the problem was solved, and that's why we had this peak of 60 data instead of the typical 20 average per day, because we had some backlog to catch up. So this is one example of if one would use this kind of regular basis, you would kind of detect this. Of course, the radiologists would also see that they don't receive the AI application. For example, in this case, at least at our site, nobody called us to say that this was the case, simply because they thought, okay, there is something wrong, and today we just don't have it. So it's interesting finding. Then, as I said, the operational is the percent of error cases. So here we see how many times there is an error. Like I said, a typical processing timeout. This is before the AI, so fail to stir contact or no signal. And you can see that there are some applications which have in proportion a quite higher level of error. So we are also investigating why this application, for example, is giving much more errors in terms of timeout or store content. We still haven't finished the investigation, so I cannot tell you exactly why we have this processing timeout, if it is just a question of type of data or I don't know. Then we look at the cases where we have that the case is not applicable. So in this case, I took again Kairos, which is the knee MRI application. We stratified for the type of MRI we have. We can see that in some cases, we have kind of 5%, but this G, we have very low volume of data. While, for example, for Philips, which is the majority of our MRI, we have a kind of 6% of error. And for Siemens, we have about 4%, but again, on a low volume. And typical not applicable cases could be, for example, that the image or the type of exam fulfills completely all the filters for the intended use. The gateway let this exam pass, but then when the when the exam application, the AI application is looking at the images, there are metal artifacts. Sorry. And therefore is not able, excuse me, to generate an output. Okay, so this is another example which is very interesting. Then the other operational KPI was the software utilization. So we wanted to see, again for Kairos, of all knee MRI performed at our group, for example, in 3 months, 1,800, how many at the end obtain an AI result, an AI report. And we see that it is 85% of the cases. We lose about 10% of cases we don't match the intended use. For example, the age, the study description, so the filter are not matched. And once the filter are matched, we still have some error, timeout or other type of description, or not compatible, like acquisition protocol, artifact, and so on. This is also very interesting if you want to see, okay, how many of your application of your exam are eventually treated, because if you arrive that you are left with 10%, maybe it's not useful to have this type of application. If you go back to the clinical, I told you that we would like to see the distribution of the clinical findings. Again, I drilled on one application just to give you some example. And what you can see is that for the Kairos application, we see that for the period we investigated, which was about 1 month, we had 80% of cases with ADAPT, 53% with findings, and 29% with no findings. Now, the ADAPT is the one you don't want, because the radiologists, normally, it's very rare that they put the ADAPT, there is something, they say, or it is normal or it is abnormal. And this is before the radiologist modifies the report. So this is how you remember I told you we have 7 features, so all the one which are drawn here, and you can see the distribution per feature. So what is interesting to see is that there are some features like the cartilage or the medial meniscal tear, which have a higher level of ADAPT than other features, like, for example, the ligament has a very low % of DAB, which means that the model needs to be improved at the level of this feature. You can also, for example, stratify by age, and logically you find that you have more, findings for older men people than young people. Now, we have not yet integrated the new graphs once the report has been corrected by the AI, so we are working on that. So I can only report you the %, but in fact, it's just what we already see, that for the femoropatellar cartilage lesion and the medial meniscal lesions, we have the majority of DAPT, that on average, about 21% of features were corrected, sometimes more than one, so on average 1.5, meaning that you had to click twice to change it. And we also found that the report were being modified much less by generalists than radiologists, meaning that, of course, the MSK radiologist is much more expert than the generalist, and therefore is changing much less. That's it. So I think I can go to the last slide of the result, which is simply representing an improvement of this software from the version 1.1 to the version 1.4, thanks also to this capability of adding the report, the Kairos report, real time by the radiologist, because we create, in fact, in the clinical workflow, a set of annotated database, which is the ground truth. So thanks to this, we were able to improve also, Incepto was able to improve the area under the ROC curve, for example, for the femoral patellar feature, which was the one, as I told you, for which we have the majority of the DAPT. So in conclusion, we were able to collect on top of clinical parameters also examination metadata. We were able to identify the typical error that we have and the typical error rate per application, which allows us also to understand internally if there are some workflow which needs to be improved. We were able to identify finding distribution, as I said, which helped to improve the AI model. And we also had a better insight on the AI volumetry and software utilization at our group that can also help in driving payment methods and develop a sustainable AI. In terms of impact, let's say that the clinical findings might be helpful for epidemiological studies. So, for example, now we are doing the same for screening mammography data, which we have submitted to RSNA. The fact that we have real-time feedback, as I said, can help generate the flow of annotated data to improve the model, the AI model. And of course, last but not least, this type of software is extremely useful for post-market surveillance, which is compulsory by the MDR. And as I told you, my last slide is about what we are going to do in the future. Well, we are busy now, but we hope to have it released soon. We are setting up, in fact, developed also by Incepto, the real-time feedback tool with for the long nodule detection and mammography. We are developing new dashboarding for mammography and chest application. And as I said, we have integrated the AI report in our structured radiology report, and we are setting up a study now to see if we can gain time in reporting. And that's it. I thank you and all my team for your attention. And I'm happy to take any question.
Thank you, Federica. Thank you very much. Very, very interesting. Sounds like a lot of work, really, both for the integration in the clinic and for the amount of metrics that you are monitoring. I will let the audience ask questions. Don't be shy.
I would be curious, in fact, to know myself if anybody in the audience has already also installed several AI applications and if they are in any way checking the safety, the performance, the errors. So this type of work that we are doing. I mean, I don't know if I can ask questions, but if nobody asks, I do have.
I have a backup question because it's my role, but it would be nice to hear a little bit of debate on.
Exactly.
Any volunteer? We have something in the chat. Yes, concerning post-market surveillance, this must be the responsibility of the supplier of the AI medical device?
Correct. So this is, in fact, it has to be the responsibility of the provider of the medical device, but of course in collaboration with I think with the customers, because they need access to data. So it has to be in clinical settings. So they need to get the data from somebody. So you need to have a kind of agreement or a study to be able to collect this data. You cannot simply give away your data to companies. That's the reality. But it's true that they are they're responsible. And that's how, for example, we did a benchmark study of AI application for bone expert, so for bone age evaluation. Bone expert, we compared and Panda, and this was a presentation we had at RSNA. And I know, for example, that Visiana, which is the company producing Bone Expert, as these were public data, use this information as some data of post-market surveillance. But of course, this is a kind of one shot. It is not a continuous real-time approach. I know, however, that because we are collaborating also with the ScreenPoint, which is the producer of Transpara, because they would be very interested to have these tools, type of tools, also for internal use, as I said, to improve their model and so on. But that's correct. The final responsible is the company who is providing the medical device.
And if anybody has another question, then I have one for you, Federica, that is a bit provocative. Allow me. So you showed us this KPI. Part of them were a bit like how well the system is working, rejection rate of data. What about diagnostic performance? And here comes the provocation. So you have the real radiologist constantly retraining your model through the feedback. So it's really like someone being in the clinic and being trained daily. Does it mean that the product will be in the end as good as the average radiologist? Mm-hmm. And if so, would that be a bad thing or not?
So thank you for the question. It's a very interesting question, and I want to clarify something. So at this moment, the model which are on the market are frozen model, which means that with the editing of the report, we just generate data, and this data do not automatically improve the model. It is not a continuous learning. So these data are then used by the manufacturer through a research agreement to improve their model. So it is not a continuous learning. The model is improved because we have this data annotated, which are the ground truth, and they can use it once we anonymize them, we follow all the ethical rules and so on to improve the model over time. Now, of course, once these data are used to improve the model is improving. And yes, we hope that this model becomes as good and maybe sometimes even better. So we had, for example, a couple of cases where the software found something, but the radiologist did not, which happens. I mean, we all know about observer performance, fatigue, satisfaction of search. So this is, you know, the software is wrong and the radiologist is wrong sometimes. So that's live, nothing to do about it. But we would like, yes, to have the software to be as good as the average radiologist. Why? Because, as I told you, we are integrating the AI report in our structured radiology report, which means that our objective is really to shorten the reporting time as much as possible, because the radiologists, there is a shortage, they are all in burnout, they have too much work. So if we can, without compromising any diagnostic accuracy and performance, reduce this time, this would be, at least for us, a great thing. Now, in the QC tool, on the long term, I think it would be very nice to start to have really ROC curve with performance level and so on. We are not yet there, but thanks to the information that you have from the default report of the AI and the corrected one, you have all the information to do so. So I don't know if you agree with that, with the fact that it will be useful, or if you had another view on that. I'm happy to hear it.
Me personally, I agree with you. I mean, it's whatever is an extra opinion, if it's founded, then it can be helpful.
Yes.
And there is a huge subsector of AI research that is just reporting, report preparation, report pre-filling. So if you can do that, that is doesn't need to be justified in terms of potential.
So I will let you know, maybe if you are accepted at the RSNA, and then I'll let you know if we manage to reduce the reading time. So we plan to do the test, you know, without AI, with AI, and with AI result integrated in the report to see if there is an evolution. It's not straightforward because there are some, how can I say, the radiologists are often distracted by phone call. They have to go to do an echo. So the study needs to be very neat to be sure that you don't have outliers, which, you know, but we'll see what it gets. We are just started.